Hello, everyone. Let's give just a second for everyone to get loaded in here. And there are a lot of us, so let's make sure we all have our cameras either off or like we're cool with them being on and they're on, and keep them muted for us. We will have time for questions and things like that. And I'm going to go ahead and pin Dr. Schuster because that should help us with everything on our end. And for those of you who don't know me, I'm Marcy Timmerman, Executive Director at Mental Health America of Kentucky, and thank you. And I will be monitoring the chat, so helping folks get in and monitoring chat.
Yes, and thank you very much for that, Marcy. I really appreciate your help with that. And with encouraging me to do this. So just judging from the number of people that RSVP'd and wanted to be in the meeting, I think it was something that was of interest. And hopefully I can provide some information and we can have some dialogue to help you all understand the SPA and the importance of making comments on it. That's really what our goal is here. So let's give folks a minute or two more. And happy day before Valentine's Day to you all. I decided to wear my red for mental health. It's always been our advocacy color in Frankfurt, but also pre-Valentine's Day seemed like the right thing to do. So is everybody pretty much in from the waiting room, Marcy?
Yes. Yep, everyone is in.
All right. So this is the captain saying, if you're on this flight and you want an informational meeting on the 1915 I state plan amendment for Kentuckians with serious mental illness or substance use disorder, then you are in the right spot. And I'm Sheila Schuster, a licensed psychologist and the longtime executive director of the Kentucky Mental Health Coalition. So let's go to the first slide, please, Marcy. And let me encourage you to type your questions in the chat, and Marcy will let me know so we can kind of answer as we go along, and then we'll have time at the end for questions as well. So why do we have this proposed 1915I? Many of you all have been in this fight for a long, long time. Consumers, family members, advocates, and providers have asked the Cabinet for Health and Family Services to develop a way to provide additional services, especially supported housing or supervised residential placements, they're calling it in the SPA, for Kentuckians with a serious mental illness that we refer to as Kentuckians with SMI. So the Cabinet has been working on this for nearly 2 years. I would say Steve Shannon and I and Kelly and a bunch of us have been working on it for 20 years maybe. We really got a boost. If you all will remember, in 2021, we had a task force of legislators that looked at severe mental illness. And out of that came a resolution that Senator Alvarado, who's no longer in the Senate because he went to Tennessee to become the Commissioner of Health down there. But that was really an impetus to get the Cabinet going, because the resolution, it was Senate Joint Resolution 72, said there will be a waiver, well, that's what we thought at the time, to provide supported housing and supported employment for people with severe mental illness. So the result of all of that work is this state plan amendment, which we've always called a waiver, but it is technically not a waiver. And I'll tell you in a few minutes how it's different from what we traditionally think of as a waiver. Next slide, please, Marcy. So is this 1915I the same as the waivers that we typically think of, and those are called the 1915C waivers. They're also called the home and community-based waivers, the HCB waivers. and some of them have been around for 30 years. And people with SMI and SUD are not eligible for them. Typically, they are for the frail elderly. They are for people with developmental intellectual disabilities. They are for people who have an acquired brain injury. There's separate waivers for that. So the ones that we typically think of as being the kind of Medicaid waivers, the home and community-based waivers are, there is one called the HCB waiver, which is a little bit confusing. There's one that's called the Michelle P waiver. There's the acquired brain injury waiver. They have one that's acute, and then also one that is long-term. And then the one that has residential services is called the Supports for Community Living, or SCL waiver. So one of the things to remember as we go through this is that each of those waivers has a limit on the number of people that can be served, or the number of slots. And I really dislike that term slots, because they're not like widgets, they're not mechanics or something, they are people. But the number of people that can be served based on the number that are funded. By contrast, our state plan amendment that we're talking about here, the 1915I, does not have any arbitrary limits on the numbers of people that can be served. The limitation is based on the number of people who meet the eligibility requirements. So I've spent a lot of time in the slides you're going to see here. And by the way, we've recorded this. We're going to post that, and we're going to send you all the slide deck either later today or tomorrow. Marcy's going to send it out to everybody who's registered. So keep in mind when we go through the eligibility requirements that that's the way that the SPA is limited, not in terms of an arbitrary number that's set, but in terms of the number of people that can meet the eligibility requirements. Each of those 1915C waivers has been developed with specific services to fit the needs of specific groups of people. As I mentioned, people with acquired brain injuries in the acute phase, or people with acquired brain injury in long-term phase, people with developmental intellectual disabilities, that kind of thing. And in that way, the 1915I is like the 1915C. The services that are being proposed are set to meet the needs of eligible people with an SMI or with an SUD. So that's how they're alike, and that's how they're different. But we're going to keep coming back to that eligibility requirement, because that really is, that's the gate that's going to admit people to these services or not. Next, please, Marcy. So the 1915I will establish a new eligibility group to receive the state plan amendment services, and they will be offered statewide. Sometimes waivers of other kinds are written to meet certain population needs in certain areas only, but these services are going to have to be offered statewide. And the overall eligibility criteria are described in these next slides. It's important to know that individual assessments will be done of each individual to determine eligibility for entrance into the SPA, and then to see which of the SPA services they would be eligible for. Marcy, I think we have a few people in the waiting room. Thank you. So think about it this way. If you meet the general eligibility requirements, you are eligible for the SPA services. But which of the services you get will be determined by the acuity of your needs. And so there's a separate evaluation based on that, and also on risk factors. And we'll talk about that in a minute. So the other thing to remember is that individuals receiving services under the SPA will remain eligible for that service as long as it's medically necessary, which is always the criteria that's used for any service in Medicaid or any service covered by insurance, but medically necessary for the person to remain in the least restrictive setting of care. So let's think about what that means. All of these waivers and SPAs are to try to keep people out of going into the most restrictive level of care. We typically think of that as nursing homes, quite frankly. with our folks, sometimes it's the state hospital, let's say, or for somebody with SUD, it would be a residential placement perhaps. So you want people to be able to remain in the community of their choice and not have to go to that highest level of restricted care. So we want people to be able to stay in the least restrictive setting of care. And we also want them to meet the goals that they've worked out with their case manager and what's called the person-centered service plan. So that's kind of like a treatment plan that has been agreed to by the individual, their caseworker, and other people working with them. So again, overall eligibility is there. And then within that, we're going to have some different criteria for different services. Next, please, Marcy. So here come the eligibility criteria. So these are the basic criteria. Have to be 18 years old or older. So this is not a children's waiver. There actually is funding in the budget in the second year of the biennium, $4 million to start developing a children's waiver that would take care of kids with SED, severe emotional disturbance, or kids that are on the autism spectrum, or kids that have significant behavioral and physical health needs. And I think many of us who also work with kids know that there's been a dearth of placements for those kids, but this waiver is for 18 years and older. So the level of need will be assessed on an individual basis using the LOCUS, which is the level of care utilization system for individuals with SMI, or using the ASAM, they call it the American Society for Addiction Medicine criteria for individuals with SUD. And later in the SPA, they list the levels that would have to be reached. It's not clear yet. I don't think they've made a determination about which providers would be administering the LOCUS or administering the ASAM. And it's not clear to me how often that would be assessed. I assume it would be assessed for entrance into the SPA, and then I don't know whether it will be reassessed at some periods of time. You also have to have what we call functional impairment in 2 of these 5 domains, and we're going to go into those a little bit more in a minute. Let's go back, Marcy. Yeah. So it's societal and role, it's interpersonal, it's daily living or personal care, it's physical, and it's cognitive and intellectual. So we'll come back to that in a minute. There has to be a duration. There has to be clinically significant behavioral health symptoms persisting continuously for at least 2 years. So you have to have some documentation. The individual is going to have some documentation about a primary diagnosis of either an SMI or an SUD, and then demonstrating clinically significant behavioral health symptoms persisting continuously for at least 2 years. And then more than one behavioral health hospitalization in the past 2 years. If you look into that a little bit more deeply, at first they were saying 60 days and they've dropped that. There now is no time limit. And placement in a CSU, a crisis stabilization unit, also counts apparently for one of these behavioral health hospitalizations. So more than one in the last 2 years. So I want to pause here for a minute, see if there are any questions. We'll go on to the functional impairment. But I guess the question to think about is, do these eligibility criteria seem reasonable? So it's literally not everybody who has any kind of SMI or SUD diagnosis. You've got to meet these other things in terms of level of need, functional impairment, duration, and then having gone to the most restrictive environment, which would be hospitalization. So keep those in mind as we go along. Remember, this SPA doesn't have limitations on numbers of people. It's all the people that meet these criteria. So what are functional impairments? Yeah, go on, Marcy, please, to the next slide. So just to show you what these functional impairments, and you have to have a functional impairment in 2 of these 5. So one is around society and roles, and it's what we typically think of. Does the conduct of the person meet the societal limits that are set by law, rules, and strong social mores? So have they been on the wrong side of the law? Have they gotten in trouble, maybe short of committing a crime, but where they have been kicked out of places or asked to leave or whatever for violating rules? And have they been, we sometimes say, inappropriate in their behavior in terms of meeting social mores? So that's one of the domains of functioning. Interpersonal is another one. Can they establish and maintain personal relationships across a range of settings? So that could be with family, could be in a work setting, it could be in a educational setting, it could be in a treatment setting for that matter. And are they able to establish and maintain personal relationships? The next one's a little bit more concrete, I think, and it's one that we think of quite often with our fellow Kentuckians who have an SMI or an SUD. Are they able to care for themselves and provide for their own needs? Now, they do make a point of saying the provision doesn't necessarily mean that they have the economic means to do it, but do they have the ability to know what they need and to make some plans to get it? So we're talking here about self-hygiene, food, transportation, clothing, shelter, all of those things that we think of in terms of all that we need to maintain ourselves or our personal selves every day. Another one is the physical area. What is their general physical health, their nutrition, their strengths, their abilities? They can also mention illnesses and injuries. So are they of reasonably good physical health? And then the last one is cognitive intellectual. What are their overall thought processes, capacity, memory, relative to their age and perhaps to their culture? So obviously the expectation for an 18-year-old is going to be different than for a 78-year-old that we might be looking at. But those are the functional impairment areas or domains that they're talking about. Remember, they have to show impairment in 2 of those 5 in order to be eligible to be in the SPA. Okay, let's go on to the next one, please, Marcy. So there also is specific eligibility for the housing related services, and there are 3 levels of housing related services that we'll go over. But just to let you know, if you're going to get any of those, which involve tenancy supports, independent living supports, and then what we call supported housing, or you have to be able to meet particular eligibility for this. So to be eligible for any of these housing related services, you have to meet just one of these risk factors. You have to be homeless, or actually have a history of being homeless in the last 24 months and now living in HUD assisted housing. You have to be, or these are all ors between these, at risk of homelessness. And that's a HUD definition. And I know we have, I saw some people coming in from the waiting room that are much more expert on this than I am. So if there's a question about that, we've got some people that can answer that. Do they have a history of frequent more than 1 time a year stays of 60 days or more in a nursing home or an inpatient setting? And again, have they been homeless in the past 24 months, now living in HUD assisted housing? And again, many of you are thinking about loved ones, or you're thinking about colleagues, or you're thinking about patients that you serve. Do these eligibility criteria for the housing services make sense in terms of, getting through that gate to get to these housing related services? And I ask these questions because I'm going to really encourage every single one of you that's in this meeting to submit comments on this waiver. It really, really, really is important that we ask questions if we don't think that what's been laid out is reasonable, or if they're missing something, or if they just have something that you think is such a barrier that very few people are going to be able to jump over that barrier to get these services. So that's why I'm emphasizing so much.
We have
And
one
how-
question.
Yeah,
First question is, who does the assessment? Actually, that one was sent to me. I'm not sure.
and I'm not sure that it's clearly laid out. I went through the frequently asked questions, and I know on the locus and the ASAM that that decision had not been made. I'm guessing that that's also true on the housing part. There may be it may be part of the history taking of the applicant. And so maybe it's done by somebody at DMS, or maybe it's done by the caseworker to answer these questions.
Okay.
And then there was a question, Marcy, about the homeless, at risk
Yep.
for
Would
homelessness.
that include individuals who live with a family member, but that arrangement isn't sustainable? I know we've had that question before. I don't know if they answered it well in the FAQ.
I did not see it answered well.
Yeah, I didn't either.
And I think that's a question that, yeah, we make sure our child's not on the streets, but permanent living is not manageable. And I think that that is a question that I know was asked at some of the town hall meetings. I didn't see it adequately answered
Same.
in the FAQ. And that's a question that probably needs to be asked over and over again, because you're almost penalizing people if they have provided housing, even under very difficult situations, to keep their family member out of homelessness. Did somebody want to?
Yeah, this is Adrian.
Hi, Adrian.
Hello.
Adrian
I
is our
had-
resident expert on from the Homeless and Housing Coalition.
Well, some of your questions that you are raising are questions that I have as well, and I also had to hop on this meeting late. Marcy, is there any way you could drop the FAQ doc, like anything you shared at the beginning of the meeting? Because I don't have it handy.
We didn't have those yet, so I will get that though.
Oh, okay, great. I was afraid I'd missed it.
Nope,
Yeah,
it's in the last slide, I think. So
okay, then I will look forward to it. Thank you.
Yeah, it's available online, Adrian, and it's 15 pages. It goes on and on. And I combed through it. What I did was I did these slides, and then I went back to the FAQ line by line to see if I was missing anything, or if I could add or clarify anything in the slides. And I know Holly asked that question about the family providing housing, and I know that we've talked about that, Holly. And I don't feel like I saw it anyplace in the FAQ.
and I think Brenda asked it too, as well, in conjunction with her issue. So
Right.
yeah, I feel like it wasn't answered properly in either one, like not fully answered the way we want it.
Right, because I would interpret couch surfing as at risk of homelessness based on common practice.
Yeah.
Go ahead, Kathy. Sorry.
No, sorry. No, what seems confusing to me is it seems like the HUD definition, parentheses there, should be up under homelessness, because HUD doesn't really look at risk, at least for the supportive housing programs. It doesn't count.
Correct.
So this looks like an expansion of the HUD homeless definition there, where they will include at risk of homelessness. But then the question is, how do you prove that? What do they? How do you demonstrate that they are at risk? Is a letter from the family enough to demonstrate that? You know, what is it? But that would appear to me, I don't know if you agree or not, Adrian, but as an expansion, going beyond the HUD definition.
Yeah,
I
would agree with that as well. Because right now, as Kathy said, like for traditional HUD homeless assistance, it is prioritized for people who are in shelter or on the street or fleeing or attempting to flee domestic violence. And while people who are couch surfing or other informal arrangements, however you want to put it, are included in the technical definition of HUD homelessness, like they're very clear that their existing programs are targeted towards street and shelter and DV homelessness. So I think it should be expanded. I'm glad that this SPA is attempting to address that category of people who are frequently left out and fall in the cracks. But I do think you are raising some excellent questions about who makes that determination, for one, and what sort of documentation is needed. As Kathy says, is a love eviction from a relative enough, or what? How is that documented?
That's excellent, and I really appreciate the input from both of you. I'm thinking of a couple of situations that I've been asked about. One is the family that is maintaining a person in their home but under great duress, where perhaps the individual with an SMI has threatened harm to one of the family members. And so there's this uneasy truce or this difficulty even in cohabiting, but there's no other alternative. And they obviously don't want the loved one to be on the street. And I'm not sure how is that an attestation from the family that says, here's all the things that we've done to accommodate this person to keep them from being homeless?
Mm-hmm.
And does that qualify for being at risk of homelessness? I think that's one kind of scenario that I've heard.
Mm-hmm.
And a lot of times this intersects too with economic conditions, in that like a family may be renting from the housing authority, like either a unit or a voucher. They may receive assistance from a housing authority, but their family member who isn't considered part of the core household and qualifies for housing assistance may be staying with them, but like housing authorities are very clear, like they have very strict guest policies and all of that. And so they, by keeping the family member with them and not putting them into literal homelessness, they're jeopardizing their own housing.
Oh, okay.
And I think that goes beyond housing authority. That's any housing,
any rental unit,
housing voucher, or rental assistance, or any unit. If the individual is not on the lease, then it's a violation of the lease to have them there more than 2 weeks.
Yeah.
Okay.
Yeah, I was talking primarily about public housing authorities, but that is pretty much across the board anymore, even in the private rental market. You're absolutely right.
Because the other scenario I'm thinking of is where the family member has SSI, SSDI coming in, and the family has arranged for them to have their own apartment paid for by that. But literally, food, clothing, I mean, everything that the person needs is provided by the family, even though the person is under a separate roof. So do they really have their own housing? I mean, I guess technically they have a roof over their head, but because of their other impairments, they really don't have the skills to maintain that. And again, that kind of interplay with the family and so forth.
Mm-hmm. That's an interesting comment, Sheila. Yeah, they have a lease, but the family is providing the supportive services.
Exactly. And the family is aging, and and there's conflict and so forth, and they're caught in that awful position that so many of our family members are caught in of, do I have to take out an MIW because they're acting strange? Do the police have to be called because X happened? I mean, and they're maintaining the person. They just happen to actually have a lease and be living someplace else.
Right.
So I think that's another issue that, and that may not be as frequent as some of these others, but obviously, and because so much of our focus has been on getting the supported housing, this is so critical. And Kelly, you want to share that with folks?
Many of us family members have just been told that our only recourse to get our family member or loved one services is to kick them out so that they would be homeless and qualify then for services. And then the other alternatives that we've been given, which are also unsatisfactory, are to continue to file involuntary commitment orders.
Yeah. Well, and
This
what we're
is a
hoping for.
This is a really important thing that we need to define, and these are excellent points that Adrian and Kathy have brought up, because without that expanded definition or some kind of attestation from the family to be enough, then we're really nowhere.
Yeah. And I think, again, the importance of really emphasizing that in our comments and coming back to it over and over again. So I really wanted, this is great conversation and so helpful, but we really need to keep this in mind as we go forward. Let's go to some of the other services so we can work through that. And again, as things come up, feel free. So what are those housing related services? And throughout this SPA, if you've read any part of it at all, it's interesting because there are some services that are provided only to those with an SMI. And then there are services that are provided whether you have an SMI or an SUD diagnosis. So housing is one of those where there's one lower level or less, less intense support is available to anybody who's eligible in the SPA. And it assists an individual in identifying, obtaining, and sustaining housing in an independent community setting. And then the two that are for the SMI only, one is in-home independent living supports, which provides individuals with assistance and training related to activities of daily living, which are called ADLs, and instrumental activities of daily living, IADLs. And then the one that I think most of us have always thought of in conjunction with this kind of waiver or SPA is the supported housing, which they're calling supervised residential care. And it provides individuals with needed residential supports while also empowering community transitions as appropriate. So those are the three housing related services. Again, the tenancy supports for SMI and SUD, and then the other two, the in-home independent living supports and the supervised residential care. But again, if you can't meet that criteria that we just talked about, homelessness or at risk of homelessness, so forth and so on, one of those, you can't qualify for any of these housing related services. Next, please, Marcy. So general services that are going to be available to both individuals with SMI and those with SUD: case management, assistive technology, supported employment, supported education, again, tenancy supports, and non-medical transportation. And then there are several services proposed that would be available only to those with SMI. We mentioned supported housing or supervised residential care, medication management, in-home independent living supports, and planned respite for caregivers, which is something that our family members have never had available to them. So that's the list of services. And again, thinking about either a loved one in your family or yourself as a consumer or somebody that you're serving as a provider of some kind. Are there any other services that you think are important that are not included here? And remember that these are services that are not available in traditional Medicaid. That's the whole purpose of a waiver or state plan amendment. Interestingly, if if a person with SMI is eligible for the 1915I SPA, they would no longer get targeted case management as it's defined under Medicaid. They would get case management within the SPA services. I don't know that day to day that the case management is all that different. The other thing for those of you, particularly the providers, if you're in the SPA, you're now in the fee-for-service Medicaid. You no longer have an MCO. So that's true of everybody who's in the waivers as well. All the people that are in the 1915C waivers are in Medicaid fee-for-service, they call it, and not under the MCOs. So you get a list of services, and again, you know, are there others? I think we have thought that the medication management would be, you know, very much a part of what our folks with SMI need out in the community. And then, you know, I don't know if the family members have ever thought about having planned respite, but, you know, might be very helpful.
I think they've thought of it.
Yeah, yes, they have thought of it. I shouldn't say, but it seemed like a pipe dream or something that was never going to happen. And it would be just very nice to think that, my gosh, it really could happen. So, those
And I got
again,
a question on that actually. Somebody was kind of wondering if you could just kind of paint a picture for what that respite would look like. Like what does that look like in other situations? Do other folks have that option? The only
respite
one
is,
I'm aware of is kids. So
well, respite is available as part of the 1915C waivers. I think all of the waivers have respite, planned respite. And the provider for that respite are the home health agencies. So there must be, and I don't know what it looks like. I don't know if there's anybody on the call who is familiar with respite services under the 1915C. Whether somebody comes into the home and provides care, allowing the caregivers to take some time away or off, or whether the individual goes someplace else for that care. I really don't know. And I don't think it's, again, in the FAQ, I don't remember it being spelled out at all. Is there anybody in the meeting that's at all familiar with respite under the other waivers?
Sheila, this is Steve Shannon. Mary Kay Lamb was on. I don't know if she's still on.
Okay.
She is on.
There you go, Mary Kay. This is for you.
Come on, Mary Kay.
It depends on the waiver. You know, supports for community living. If they're in a staff residence, there's really not a respite component. Michelle P. waiver offers respite relief of the primary caregiver. Again, we get into the complications, Steve and Sheila, of are they participant directing that service? If they are, they can hire their respite caregiver out of those dollars. Home and community-based waiver, that is correct. It is through a home health agency. So it varies from waiver to waiver as to that respite component and how that is delivered. They have recently, under the Supports for Community Living for family home providers during COVID, they did the amendment to where the family home providers could also have respite. My understanding is that's going to go forward. So there can be another caregiver that either comes into their home, or that individual that they're supporting in the family home go to another family home provider, as long as they're an SCL provider. So it's a little bit different per the waiver. ABI, the majority that we deal with are participant direct, and there's a respite component there that they can hire someone that's had training and passed all the background checks to do their respite for them as well. So I don't know if that helped at all, but it's a little bit different in all the waivers.
Mary Kay, this is Steve
Yes.
Shannon again. I'm going to ask you some questions. Um,
Okay,
what is
Steve.
a family home? What's a family home provider?
It is like adult foster care.
Okay. And what's PDS?
Participant directed services,
And what,
where the individual funding goes to a representative and the family to direct services as they would like those services to be delivered by employees that they hire to provide those services with a representative that is not paid to help direct those services. The one service you have to have that's traditional is case management. The rest of the services can be participant directed. And so those dollars based on their person-centered plan directs what services can be purchased for that individual to be delivered in the environment within their home.
so I think a great question, Sheila, would be, one, will this participant-driven support or services be part of this waiver,
And
right?
I've been told no.
Yeah, the
Okay.
answer to that is no. I did see that in the FAQ, Steve. So for people that are familiar with PDS, as Mary Kay defined it, where they get the money and they essentially hire their own providers, if you will, that is not a part of this SPA. And they also, the family home provider is not a part of this SPA.
And do
So
you think if there's enough comments on those two topics, it could be changed?
well,
Or at
that's an
least plant the
interesting
seed?
question. Yeah, yeah.
Well, I mean, I don't have a lot of familiarity with the person directed. I have a little, and and Mary Kay, you're the expert here, but my exposure to it was, the family just found somebody in the community who was willing to work with their loved one, and did cleaning for them and would take them out to, like, for coffee or social time, depending on their goals and needs, I guess. But if we have clients who, have very little insight into having an illness, I don't know. And then the family homes, again, Mary Kay, you correct me, because I'm going back a long way, but many of these folks who we're describing here who have challenging behaviors, and that would be challenging in some of the homes that, at least, that I've been familiar with. But Mary Kay, you correct me on any of that.
You're correct. I mean, the participant directed services, they're kind of different in all the waivers as to what they call them, like, community integration or, participant directed service or, activities of daily living. It's all somewhat called differently in all the waivers. The people do have to go through background checks. They have to go through a certain amount of training. So it's just not anybody off the street, and that is monitored pretty heavily by the case management component. The family home providers, that's, we support several people through supports with community living that primary diagnosis is ID, but there is also a component, a mental health component there as well. Some do very, very well with the family home providers versus, say, a staffed residence where there can be no more than 3 individuals in a home with 24/7 staff. They do better in the family home environment. So again, it's very much based on the individual and choice. I guess my issue with some of these services, it's not leaving a lot of choice to individuals and how they would like their services delivered, and the people that are important to them in their lives that support them as to, what's available to them.
They
I hope
did
that,
talk, did they talk about persons? Sheila, did you not talk about person-centered planning?
Yes.
Okay.
Yeah, they have a personal goals and so forth, but that's not the PDS.
No, I get it.
Yeah, yeah, but they do have, I forgot what it's called. It was in an earlier slide. They do have the person-directed goals, I think it's called.
person-centered planning. Mhm.
Person-centered planning.
PCP.
Yeah. But that's an
Sheila?
interesting question about choice. Yeah, yeah.
I just wanted to build a little bit on what Kathy Dobbins was saying, and that is about with the ACT teams and stuff, we've seen some of our folks refuse to participate in the services. And then the next thing we know, they're not able to be served by the ACT team anymore, and so on and so forth. Would there be penalties involved for people if they didn't allow these things to happen and they were participating in the SPA waiver or the SPA plan?
That's a great question, Kelly, and I didn't see anything. And we know that
Because what
many of
we're
our
getting
folks,
into is the
yeah,
people that need it the most are the sickest, won't let the people in their house or won't participate or won't do what they're supposed to keep appointments. And then the next thing you know, they're no longer eligible. So I'm wondering if there's going to be measures like that that would cause them to be kicked out of the program or whatever, because we've certainly run into a lot of that.
I think that's a good question to ask, and I didn't see anything in the write-up of the SPA or in certainly in the FAQs. And we certainly hear that. We hear it around Tibbs Law.
Yes.
We hear it around participation with the ACT teams. We hear it in terms, obviously, of taking medications and so forth.
I mean, the same issues that the family has and the reason they can no longer house or help the individual become the systemic problems that the providers have. And we run into that over and over and over again.
Yeah, yeah. All right, great.
I agree.
Yeah.
So to
Adrian,
bring us back out of the weeds, I have one quick question from
Yeah.
that is before Adrian, and you can't see it. Sorry. It's a more general question. Somebody was wondering if therapy and psychiatry would be included as services under this waiver, or are those assumed to be present with other care, like other coverage?
that's a great question.
I'm summarizing because that's how
I'm just thinking that, you know, the very basics of being diagnosed, being treated, getting their medications are kind of assumed in this.
yeah.
And I
But they're
don't,
not spelled out, right?
but they are not spelled out. Isn't that interesting?
Yeah, but there's still regular state plan services, right? So I don't know if it would be included in the 1915I because it's in the state
yeah.
plan.
I
The other
bet
That's
way,
why I
it's
asked,
carved
is
out.
it assumed to be there already?
yeah,
But I bet it's carved out of the waiver. Psychiatry is, I'm sure psychiatry is carved out. Be separate, outside of the
yeah,
waiver.
it's a state plan service. That's so
Exactly.
it stays there. It's
It's
not a
the same with the
1915I service.
HCB waivers that
Okay.
psychiatry and therapy are, like Steve said, just a state plan amendment service that they bill the regular, they will have a fee for service Medicaid that they bill for that service.
Okay. Yeah. That's what you would assume, but yeah. And that would also be true of their physical health care,
Right.
right? Anything that comes up that would all be covered under the state plan. And then this is kind of in addition to that. So yeah, I mean, it is kind of interesting that all of a sudden you're like, oh yeah, there's real basic services.
So would that
So-
impact a private insurance plan that somebody has on their child, or is it able to include them up to 26, right? So would that disclude them from the waiver if they have those other options?
They have to have Medicaid, don't they?
Yeah, they have to have Medicaid, but what
Okay.
you're saying is that you could have, somebody could cover them up to age 26
Right.
on their commercial plan. So you could be dual eligible, commercial plan and Medicaid.
Okay.
I don't know how you would, who pays for what in that case.
And I think if you get the waiver, why would you not drop the commercial plan?
Yeah, that makes sense to me. I just wondered, there's some people that'll have strong feelings from a political standpoint, probably, but otherwise I was just thinking.
Yeah, yeah.
I'm not aware that you can be covered under a commercial plan and Medicaid at the same time.
Oh, yeah, it helps
You
with kids
can.
all the time.
Okay,
Yeah.
all right, okay.
Yeah. And so kids, we think of kids as, under
Right.
18, but you could be carried as a dependent on your parents' insurance plan until age 26.
Okay,
So
all
you
right.
could have a young
That's
adult
true. That's true.
gotten, and is
On our
Medicaid.
transitional youth are covered till 26 because of that too,
Right.
because the state's
Right.
independent. So yeah.
Adrian, I think you put in
All
the
right.
chat that you had read through the FAQs and it was not clear to you who would actually be doing those assessments, right?
That's correct. So I went back and thank you for reminding me that Google exists, Dr. Schuster. I went back because I'm not as familiar with HUD's flow chart, if you will, on at risk of homelessness, just because in dealing with homeless assistance, we never actually get to use that. So it's kind of pointless. And so like to Holly's example, like the household who has the family member that they're trying to prevent from like being literally homeless, but the situation is not tenable. They would qualify under the at-risk category if they had an annual income below 30% of the median family income for the area, and they do not have sufficient resources or support networks immediately available to prevent them from moving to an emergency shelter or another place defined in category 1 of the homeless definition, so i.e. the street. So you've got 1, 2, and meets one of the following conditions, of which there are 6. 1, for economic reasons, moving 2 or more times during the prior 60 days, is living in the home of another because of economic hardship, has been notified that their right to occupy their current housing will be terminated within 21 days, lives in a hotel or motel and the cost is not paid for by charitable organizations, lives in an SRO or efficiency apartment where 2 or more people live, or a larger housing unit where there reside more than 1.5 persons per room, or is exiting a publicly funded institution or system of care, or otherwise lives in housing that has characteristics associated with instability and an increased risk of homelessness as identified in the recipient's approved con plan. That is a lot of words. That's too many words. I wish that they had just said at risk of homelessness due to couch surfing, economic hardship, blah, 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 blah. So I think we can say in our comments, you need to simplify that, because that gets back to my second question, or the open question of who is making that determination. If I am looking at the proposed providers that they think are going to carry out the activities of this spa, none of those folks typically deal, none of, except one of those groups of folks, providers, typically deal with HUD homeless assistance and have to deal with that nonsense of documentation. Some of the community mental health centers do see the continuum of care and HUD funded homeless assistance, so they should have the capacity to make those determinations. But yeah, anyway, those are my thoughts on that, having actually done the homework now.
Okay, thank you. So basically, we want them to really specify, and we want to be sure that whoever's doing the determination is somebody that understands homelessness and the HUD definitions, but it'd really be nice if it were someone that also understood SMI and SUD. Is that asking?
Right. because they lay it out on the medical side of it, if I'm not mistaken, and this is not my area of expertise, so you may like say the ASAM and the other one that I can't even remember.
Locust.
Yes, that one. Like, I don't know if those are the appropriate assessments. But I don't think that they get to housing status. I don't think they ask any questions about it. So that leads me to think, well, there's going to have to be another housing assessment done to get through basically the flow chart of whether they're housing eligible.
Right, right.
So they need to specify that.
Yeah. Excellent.
I will
Okay.
also, so to jump from Adrian's very salient points, and thank you, Adrian, for researching that and giving me that information. Some individuals who also have an IDD can have insurance under, for example, in our case, there is a court order that a parent has to carry them on a personal insurance until they are 21. But he also would qualify for Medicaid. So that could also be a possibility, not just that a parent wants to carry them, but a parent has to carry them because there's a court order. The other question that I have here is, we talked about psychiatric services and medications and doctor's visits and things like that. Is transportation going to be provided to those appointments?
They list transportation as one of the services offered. And it's not clear to me, Holly, whether it's different from the way that Medicaid now does NEMT, non-emergency medical transportation, which is not a very functional system.
No, it's not.
So I don't know. That's another good question to ask.
Okay.
Yeah. Excellent question. All right, Marcy, let's move along to, somebody's just put in the chat, there's a new edition of ASAM level of care placement, which does include, lost it. Do you see it in the chat, Marcy?
Yeah, it does include placement for recovery housing. In this spot, does it speak to the most recent version of ASAM? Judy, I think that's the ASAM that was just released in June, and they did include that.
So it's a good question. And maybe we want to say that the SPA should specify the most recent versions or the most recent editions of the locus and the ASAM.
Yeah, that makes sense, rather than sticking it to what it was when we wrote it, right?
Right.
Yeah, as far as, could I say something about the locus real quick?
Sure.
So this is Lela still. I'm a director of social work at Eastern State. So it had come up. We've been asking for some additional locus training for a while, just with new social workers, because it's an assessment we do quite a bit, and it does assess the housing piece. You know, basically a level 4 is ACT, 5 is PCH or other supportive housing, and 6 is a hospital. But the issue is, I guess the state basically, we had a few people, it's probably been 10 years ago, but trained the trainers for the locus, who then could train people at our agencies. I'm pretty sure that is all, it sounds like, kind of null and void since they've revised the locus. So that's one of the things that I was going to talk to our hospital leadership about, was that we need updated training, because I don't think, and I know lots of people use the CMHCs, hospitals use the locus, but it sounds like either, you know, DBH could purchase that and offer that again for the hospitals and CMHCs, or we're all going to have to do it individually, purchase it individually, if that makes sense. I don't know if that's helpful or not.
Yeah, that's very helpful. A piece that we hadn't thought about, but if you're going to put all of your eggs in the basket of the locus or the ASAM, let's be sure that it's the most recent version, and let's be sure that we have enough providers trained to actually use it appropriately.
Sheila, this is Mary Kay. Not too long ago, the department did send out a survey to the CMHCs about how many trainers were still active in the CMHCs, which led me to believe they might be looking at bringing in train the trainers again. It was probably
Okay.
about 4 months ago.
Great.
Okay.
Yeah, the last we heard just in the last couple of weeks is they weren't going to do it. So yeah, if we could get that
Oh,
again, that would be awesome.
All right, so we need to push for that. Yeah, thank you. And I should point out that Mary Kay, who's been so helpful, is from River Valley Behavioral Health. We appreciate your being on, Mary Kay. And thank you for that, from Eastern State Hospital. I missed your name.
That was Lola Still.
Oh, Lois.
Thanks,
Okay,
Lola.
thank you. Yeah. So these are the spa services only for people with SMI, the in-home independent living supports, supervised residential care, which is the supported housing, medication management, and then the planned respite for caregivers. And I think we've talked about all of these in one time or another. So again, the independent living supports and the supervised residential care fall into that housing category. So you got to meet those additional criteria of homelessness or at risk of homelessness or yada, yada. Everybody should be with an SMI should be getting medication management, which is education and training to facilitate their adherence to the medication. And then again, the planned respite, and they emphasize short-term relief. So again, we're not quite sure what that looks like. I think if family members want to ask more specific questions or would like to have them spell out more about what that respite looks like, I think that would certainly be very appropriate. Next, Marcy, please. Was there another question in the chat?
Sorry, the toolbar keeps screwing up for me. The question in the chat was from Val about hospitalization. She said it looks like crisis stabilization is included in the requirement of 2 hospitalizations. Is that how you understood it?
It will count toward it, yes.
Okay. And she was asking if there's a minimal number of days per hospitalization to
No,
qualify.
interestingly, there is no length of stay or LOS requirement. So it doesn't have to be, a 5 or more or 3 or more, or yeah, it's pretty loose, I guess. The one that's really the 60-day one that I mentioned earlier was actually on the housing criteria. One of the criteria that would help you get housing is if you were 60 days or more in a nursing home or in a hospital. And I remember, I think, Kathy, you and I were on the same Zoom with them saying, who the heck ever
Right.
goes to the hospital for 60 days, unless it's for, some physical medical thing. So that doesn't seem to work. So these are the spa services that would be available for the SMI and SUD. And again, the tenancy supports as part of the housing. And then you have supported education and supported employment, assistive technology, case management, and there's the non-medical transportation, which is different than NEMT. Let's think about this. The Medicaid transportation is non-emergency medical transportation. So that's to get people to their doctor's appointment, not to get them to the ER if they're in acute distress. This is non-medical transportation, which is a whole different thing. So apparently they're gonna, well, do we assume that they're gonna have both? And now I can't remember if I saw in the FAQs that they are eligible for NEMT as well as this. I'm gonna assume that a state plan, do you know, Steve, does the state plan include NEMT? Or Mary Kay may know that. I'm guessing that it does. But we could ask, so do they get non-emergency medical transportation and then they get non-medical transportation?
I'll verify and we'll respond with the email to everybody when we send out the slides and the report.
Yeah, great. All right, and next. So here's what we know about providers so far. So they want to have a big range of providers because they want to be able to have ease of access throughout the state. So the providers who are currently approved are all of those who are currently providing services under the home and community-based waivers. So they're providing similar services to what we're talking about here. Remember, those same services by and large are available in the 1915C waivers. It does include community mental health centers. It does include community rehabilitation programs. That's only for supported education and supported employment. The home health agencies would be for planned respite for caregivers. And then they have apparently other Medicaid approved providers for supported education. I know at the town hall meetings, there were a number of questions asked by the BHSOs, Wellspring, Ridgehaven, New Beginnings, providers like that. And they did make a point to say that they can apply to be 1915I service providers. And I don't know, Kathy, or I saw Brad Leedy got on, if you all have heard anything other than that or in addition to that. Because I know that there were questions about it.
No, I haven't really followed up on that. Haven't heard anything more.
Okay.
We haven't heard anything either.
Okay. Well, you all know this population of SMI probably as well as anybody does. So I'm assuming and hoping that you all will be recognized as providers under this.
I'm assuming that too, for those of us who know this population and know this work pretty well.
Yeah. Well, and particularly in your case, Kathy and Christy Shuffett and people over at New Beginnings and similar organizations that are working with the housing piece as well, know it so well. So it only makes sense. And there was no mention of the AODs, the alcohol and other drug entities. Since this is an SUD population, I'm wondering if that same thing would be true, that they could apply to be service providers. I've not heard anything. And there were no questions asked about that I'm aware of. And it was not in the FAQ. So that's another whole set of SUD providers out there.
There are SUD providers who are BHSOs.
BHSOs, that's true. I'd forgotten that, but there are many, many more that are AODEs. So we'll see, but that, should be a wide provider network, I think. Next, please. So just to remind you, the reason that we're really emphasizing this is that we're in a ticking time bomb, if you will. This is a required 30-day public comment period. And whenever the DMS or any Medicaid in any state wants to propose a state plan amendment or a waiver, it has to allow input from the people and communities that would be affected by the new program. So this is that period. They announced it on January 29th, and it will end at midnight on February 28th. So it doesn't carry over to February 29th, that odd day that we have every 4 years. So remember, it really does end on February 28th. Supposedly, when they get this input from us, they will review their proposal and may make changes in it in response to the comments. I'm not holding my breath, but good things could happen. Whatever they come up with, then that's our last chance locally in Kentucky to have any comment on it. They will then forward that proposed 1915I SPA to CMS for their review, and CMS will have a 30-day federal comment period during which the comments that we made here can be shared with CMS. You also can send them in directly to CMS, and I'm sure they will have a link for that. So there's kind of 2 bites at the apple. The more important one, in my view, is here in Kentucky. to really weigh in on some of the excellent questions that we've already raised. Next, please, Marcy. So why is it so important? Many of you at this meeting or reading this have the most important perspective on SMI and SUD, and it's that you and your loved ones have lived experience with these illnesses. I don't think that anyone who wrote this SPA, I'm not aware of anyone who wrote this SPA having lived experience with an SMI or an SUD. I mean, they may, and I just don't know it, but you all are the experts. Or you're a provider of services and have so many experiences to share in that regard. And because of that, you know best what services have been missing and what people need to stay in recovery and to thrive in their lives, actually. So we all want the SPA to be the very best it can be. And unless we speak up, we will have missed this opportunity, I think, to shape the SPA. Some of you were on a webinar yesterday that Thrive Kentucky did with the cabinet, and Pam Smith, who's head of support services, or I forget what her title is, but anyway, she takes care of all the waivers, and she's kind of riding herd on the 1915 SPA, said they were very disappointed. They had only received 5 comments so far. Now they've only had an open, 10 days or not quite 10 days. I want to show her that there are a lot of us out here that want to make comments. Next, please. So DMS sent out, and there's a link to it. There's lots of ways that they are making it available. There's an email address you can send it to. There's actually a phone number where they say that they will have someone answering the phone. Our experience with phone answering at the cabinet level has not been altogether great. So we went on and took advantage of our colleagues at Kentucky Voices for Health. And many of you are familiar with their comment collectors. Their biggest victory, our biggest victory, because I'm chair of that board, was back in the Bevin administration, where Governor Bevin wanted to add a very onerous work requirement to Medicaid that would have kicked a bunch of people off. And as you all probably know, most people that are on Medicaid do work. They just work at jobs that don't pay enough and don't have any kind of insurance. But the paperwork and the frequency of reporting and so forth was going to kick people off. And KVH collected, I think, 12,000 comments or some incredible number of comments, and sent them on to CMS. And the judge who ruled in the case, because it was thrown out and then it was appealed to the federal appellate court, and the judge, I think twice in his opinion, in batting down the work requirement, referenced all of those comments and said, obviously, those comments were not asked for by the administration in Kentucky, or else they would never have brought forward this recommendation and so forth. So that's the power of these comments. So we've developed a comment collector, and we think it's going to be easier for you to respond to it, because what we've done is to ask you specific questions about the various things that we've talked about today. Are the services what you think are appropriate? Are the eligibility requirements what you think are appropriate? So it's a yes or no almost kind of answer on a couple of those things. And then lots of opportunity for you to share other comments. How have you or your family or the people you work with been served by Medicaid? What have you seen as the gaps in the system? What do you think are the 1 or 2 most important services that the person that you're most concerned about, or the group of people that you're most concerned about? I'm guessing that you could go through that 5 minutes, at the most, probably 10 minutes, particularly after you've gotten some familiarity with what we've talked about today. Yes, Roland, we're going to send the slides out with these links and so forth. The other good thing, if you use the comment collector, is that KBH will make sure that not only are all of those comments, every comment and suggestion is shared with DMS before the deadline, but when CMS in DC opens its comment periods, its comment period, your comments will also be shared with CMS. So it's kind of a one-stop shop, and I hope you will take advantage of it. And I think we have one more slide, Marcy. Yeah, additional information. So just a reminder that DMS has produced a ton of documents about this, and that's the general place to go. BHI stands for Behavioral Health Initiative. So that's a web page on the, yeah, this link doesn't take you there, Kathy. This link on the DMS website has a document that tells you where you could send your comments directly to DMS if you want to do that. I think we put the URL in, didn't we, Marcy? For the comment collector?
I thought I did, but I might have pulled the wrong one, I'm guessing.
Go back a slide, because I thought we had it in there.
We did the tiny URL, right?
Yeah, the tiny URL should take you right to it. So what you just put in the
comment,
Marcy, what you just put in the chat is the DMS website.
Yeah. I don't know where that link is right off. I'm sorry.
Here, Alex just put it in there for us.
Thanks, Alex.
Thank goodness.
Sorry about that.
I also just want to thank my colleagues at, go ahead to the last slide if you don't mind. Mental Health America of Kentucky, and NAMI Kentucky for support for this informational meeting. Jaden has been very helpful in getting the word out to all of the NAMI affiliates and so forth, and certainly thanks to Kentucky Voices for Health. But the most important thanks, I think, goes to the consumers and family members who have been in this for a long time and have shown up and spoken up and never given up the fight. So you rock, you all. So thank you very much. And we can take this down and see if there's any other questions or comments that anybody wants to share.